Okay. Thank you guys for having me back again. I've been here before twice actually speaking about artificial urinary sphincters, and then usually I say I'll come back and talk about penile prostheses, and then this time I came back to talk about the green light laser. Now the reason I think Bob had asked somebody from urology to speak about the green light laser because there was a controversy there was a controversy a couple of weeks ago in the media about the green light laser. And I followed it and read the reports in the Calgary Herald, and the media got many things right and many things wrong. If you were reading it, sometimes it talked about the green light laser being a treatment for prostate cancer. And given this is a prostate cancer support group, you might be thinking the green light laser must be a treatment for prostate cancer. It is not a treatment for prostate cancer. So that's not what it is. It's also, they compared it in one of the articles, comparing it to the traditional open surgery. It's not in comparison to the traditional open surgery, it's in comparison to the typical transurethral resection of the prostate, or the Roto-Rooter job that many people have heard about. But all of these are treatments for prostate enlargement. Now I know that some people in this room have had cryotherapy, I know some people have had brachytherapy, I know some people have had radiation therapy, and after some of those therapies, some of you may have had trouble passing your water, and someone like Dr. Donnelly or one of the urologists may have gone in and done a Roto-Rooter job. But it's important to understand before I even start, the Roto-Rooter job was not done for your prostate cancer. It was done because there was a prostate obstruction, and Dr. Donnelly or whoever had to clear your passage. And that's what this green light laser is. It's basically a procedure to open up the waterworks for men with prostate enlargement. They may have prostate cancer, but that's not why we're doing it. We're doing it because they were having trouble peeing. And so we'll come back to that, but up front I wanted to be honest, this is not a new fancy treatment for prostate cancer and you're all regretting, oh my goodness, I can't believe I had surgery because I could have had the green light laser. That's not what this is. So up front, the goals of my talk were basically to talk about BPH, or prostate enlargement. And many men in this room have prostate cancer, but actually what started out is you went to see your doctor maybe because you had trouble passing your water. The doctor said, let's do a PSA. The PSA led to the finger exam. The finger exam led to a urologist. The urologist did a biopsy. The biopsy showed prostate cancer. And then next thing you know, your prostate cancer is being treated, even though you went to see the doctor up front because you were having trouble peeing. And a lot of people will say, well, you know, what happened to my trouble peeing? But it's possible for men to have prostate enlargement and prostate cancer. And so what I'm talking about here, though, is prostate enlargement. And I'm not talking about prostate cancer. I'm happy to. It's what I talk about all the time. But this is prostate enlargement. So this may have been the first thing that made you go see your doctor, and it may have actually led down the road to prostate cancer, but up front, this is prostate enlargement. This is getting up to pee at night. This is a slow stream. We're going to talk about prostate enlargement. We're going to talk about medications that we use in urology, things that you may have been on at one time or another, Flomax, Proscar, Avodart, and then we're going to talk about surgery, and that's when we come back to the green light laser, the standard TURP or Roto-Rooter. So in general, I know everybody here has got a prostate or had a prostate, except the ladies. And it's a walnut-sized gland that sits just below the bladder. It doesn't serve any purpose except to provide fluid to support the sperm on their journey to meet the egg. And so that's why you can live a nice life without a prostate, or that's why you can radiate a prostate, is because it's not an important organ for digestion. It's not your brain. It's nothing more than an organ that secretes a fluid to support the sperm. And so after you have finished having children, you don't have to have a prostate. But a lot of people will say to me, well, I've had a vasectomy, so my prostate doesn't matter. But it's different. The vasectomy stops the sperm. The prostate produces the fluid that supports the sperm. And altogether, it makes the ejaculate, which comes out the end of the penis during sex. Now, Doc says I've got an enlarged prostate, or BPH. What do we mean by that? Because we say it all the time to patients. In general, I've got an enlarged prostate or a big prostate, and it's causing me trouble. It's squeezing around the water channel, and it's gotten enlarged. A normal prostate is about 20 grams, like a walnut. As it grows, it can grow to a mandarin orange, it can grow to a navel orange, a grapefruit size. And size can mean symptoms, but many men that had prostate cancer, we found out on your biopsy that you had an enlarged prostate, and then you said right back to us, but I might have a large prostate, but I'm not having any trouble. So just because you have an enlarged prostate doesn't mean you have to have symptoms, but an enlarged prostate may mean that you have symptoms, and we're going to come to that. When we say BPH, we mean benign, so non-cancer, prostatic hyperplasia, or prostate enlargement. And from a medical point of view, there's actually a reason for that. If you go inside the prostate, it's making more glands and more cells. But these are normal. They're not cancer. They're normal cells. So prostate cancer is abnormal cells. BPH is normal cells, just too many of them. So in general, a normal prostate surrounds the urethra, and an enlarged prostate surrounds the urethra, but it squeezes. Just imagine that you're just squeezing off the water channel. So as it enlarges, some people will have trouble passing their water. And it's not life-threatening. I tell patients it's quality of life-threatening. It's really annoying to have a slow stream. It's annoying to get up at night. It's annoying to get a sudden urge that you can't control and you have to get there. It's annoying to get to the mall and need to know where the bathroom is at all times. But again, it's not cancer, it's not life-threatening, but it's quality of life-threatening, and that's why there's so many treatments, because in urology, what I do, we spend a lot of time just making people's life better from their waterworks point of view. So here's just another image that I found, and I like the word how BPH squashes the urethra. So pretty much that's what it's doing as the prostate enlarges. In this lower picture, it's actually squeezing across the water channel and preventing the person from passing their water. And you can see the muscle of the bladder has gotten enlarged, and the person will say, I'm having trouble emptying my bladder. I feel like I got to go back. My stream is slow. And again, a lot of people that have undergone prostate cancer therapy, like cryotherapy, radiation therapy, they may say, all of this sounds exactly like me. But urology many things can be the same thing, and trouble passing your water after radiation or cryotherapy can be very similar to this, where there's a squeeze on the water channel. But again, this is non-cancer enlargement. So we like to tell people there's two components. There's a static component, which means that it's just a bulk, it's just sitting there. And there's a dynamic component, and that is there's increased muscle tone. So as the prostate enlarges, there's just a size that squeezes on the water channel. And then there's also an increased amount of muscle tissue in there, what we call alpha fibers. And the reason I say alpha fibers is when I say alpha blockers, they block the alpha fibers. So we've got a static component, which is just from a large prostate, and then we've got a dynamic component, which is from squeezing on the water channel. And those two components are important because each one potentially has a different treatment. There's one set of drugs that shrink the prostate, and then we have another set of medications that relax the prostate. So how common is BPH? Well, if you do autopsies of 80-year-old men, 80% of them have some type of prostate enlargement. So it's very common as we age. It's common in people from Asia, India, as well as people from North America. So we will see men from many cultures, which I find interesting because prostate cancer is not necessarily something that we see spread out throughout so many cultures. But it is possible in all parts of the world. But some cultures seem to have less risk of prostate cancer. Some cultures have more risk, such as patients that are African American have a 2.5 times risk of prostate cancer. Prostate enlargement is spread out throughout the population, and we'll see it. As people age, they tend to get increased trouble passing their water, and most of them chalk it up to aging. we use a number of terms. So if you came to see a urologist originally, we may have said, hey, doc says I've got BPH. So that's benign prostate obstruction. We also use the word lower urinary tract symptoms, or LUTS. And so when we write back to your doctor and say, Mr. Smith complains of LUTS, we're meaning lower urinary tract symptoms. And I'm going to come to what those are, but they're the things that you complain to your doctor about. I get up at night, I got to go suddenly, and my stream is really slow. The old word that people used to say was prostatism. Prostatism, it's not prostate cancer, it's not prostate infection, it's just an enlargement of the prostate. We tried to get rid of that word, and so we try and use these words because they describe more what's going on. I like this picture because it shows the changes. As you get a big prostate, you get squeezing of the water channel. The muscle of the bladder gets really thick because it's trying to push that urine out, but there's a blockage. The bladder itself gets irregular, and you can see those swirly lines within it, and those are just muscle fibers getting bigger and bigger, and they're trying to do the work of getting it past the prostate blockage. There's a lot going on in the prostate. To get a prostate enlargement, you have to have testosterone, and you have to have a prostate. So people that don't have testosterone, and there aren't that many men that don't have testosterone, but there are men after prostate cancer treatments that will have their testosterone eliminated. And in some ways, a man may present to us with prostate cancer. He may be having some trouble passing his water, but his prostate cancer can be at such a point that the treatments become hormone therapy. And so we will put the man on hormone therapy, and as a side effect of the hormones, by eliminating his testosterone, he will start to pass his water better. And that's because I said men can have prostate enlargement, men can have prostate cancer. And so if you treat the prostate cancer by eliminating the testosterone, you may get a benefit of passing the water. The prostate will shrink and reduce in size and relax. So, can you spell your name in the snow? When you were a kid, everybody could do that, spell their name in the snow. But as many of you age, you can go out and try it, but many of you won't be able to do it. If you can, fantastic, you should show your friends. But for us, I spend a lot of my time trying to figure out how can I help a man pass his water better, and there's certain things that I do. I want to know things on history. I want to know when I examine him. I may get him to pass water into our special machine and see how his curve is. We may do an ultrasound, and we may do a cystoscopy. Many of you in this room have probably had a cystoscopy. That's where we pass the flexible scope into the bladder, and we're looking for various things. Maybe you passed blood on one occasion. Maybe you had trouble passing your water after your radiation or your cryotherapy, and so a urologist was asked to look in your bladder. I like this cartoon I found because this pretty much shows what men will experience. In the top corner, interruption in the urinary stream, the start-stop. Hesitation before beginning to urinate. The man is pushing against the wall, almost begging for his penis to release the urine. Terminal dribbling, that is when you're finished, you think you're all done, you zip up your fly, you walk away, and out comes some leakage that came out after. An urgent need to urinate, that's when you drive into the driveway, the door goes up, and oh my God, you've got to pee right now before you get to the toilet. A weak urinary stream, you can't even pass your water. You definitely can't take the shine off of the toilet anymore like you could as a kid. A feeling that the bladder is still full, so you walked away and you still feel like you need to pee, and then a frequent desire to urinate, especially at night. And those are all symptoms that can be related to prostate enlargement. Here they are listed as what we call obstruction. So obstruction of justice, obstruction of the force of something. So slow stream, hesitancy, you get to the toilet and can't go. Intermittent, that's a start-stop, straining to void, and incomplete emptying. But there's also irritative things, so there's obstruction and irritation. Irritative symptoms, you've got an urgency, you've got to go right now and look out. And if you don't go right now, you may get the last one, urgency incontinence. That's where you didn't make it and you got it started in your pad or in your pants. Frequency, that means you've got to go often. What is the definition of often? Normal is up to 8 Ps per day. So perhaps you're going 15 or 20 times per day. Nocturia, that's our special word for going pee at night. It's normal to get up once per night. More than that is considered abnormal. But again, it comes down to, does it bother you getting up? If you don't have anything else to do the next day, or you can fall back to sleep, you probably aren't that bothered. Dysuria, that's our special word for burning to pee. And many of you have probably experienced burning to pee after you had a catheter or around the time of your radical prostatectomy, maybe some burning after radiation or brachytherapy. And burning to pee can be a symptom of prostate enlargement. When I talk to you, there's usually things I want to know. Have you ever had a bladder infection? Did you ever pee blood and you saw it yourself? Have you had any previous prostate surgery, either cryotherapy, radiation? Had you had a Roto-Rooter job done years ago, maybe when you lived in Winnipeg? Are you on a water pill that might be affecting how often you pass your water? And what do you have for caffeine in the day? I see lots of people that have 2 and 3 pots of coffee per day, which is a lot, if you're wondering. So if you have 4, that's a lot. Is there still a role for the prostate exam? Absolutely. We've got to remember, in front of me is a man. The man could have prostate cancer. He may have prostate enlargement. He may have prostate infection. And so there's still a role for prostate exam, and that's basically our feel of the backside of the prostate, and we're checking for size, nodules, does it feel symmetric, and is it boggy or tender, which can indicate an infection or abscess. Other things, we may send you for a urine culture just to make sure we're not missing infection, because burning, frequency, blood in the urine, getting up at night could all be an infection. And so an antibiotic may treat it a lot better than a medication to shrink or relax your prostate. The role of a PSA, definitely in this organization, PSA is obviously the starting point for a lot of what you guys have gone through. PSA is controversial in the media lately, but typical media, they do a great job at raising controversy and not solving the issue. PSA is still a recommended test. And I know I'm preaching to the converted here, but the media really did a job showing that PSA was negative after some huge studies were released from Europe and America. But basically, when you boil them down, it does look like PSA is saving lives. Again, you might be wondering, what is this guy talking about? Of course PSA saves lives, but there was controversy, and even Alberta Health Services doesn't currently fund PSA as a screening test in this province. And so they would say, well, we don't fund it because you haven't proven that you've saved lives. And we now have a study from Europe which appears to show that PSA saves lives. So we may see that change down the road here. Urinary flow rate, that's passing water into our special machine to see the way you pass your water, and an ultrasound and cystoscopy. What are the types of things we see at cystoscopy? So that black scope there, that's me looking all the way back at your prostate. And there, on that one picture, there's a large middle lobe of the prostate. On this image, there's 2 lobes of the prostate squeezing together on the water channel. And those are very dramatic. They show an obvious prostate enlargement. And we may or may not see that at the time, but these are good pictures that show it. What happens to most men? Most men that come to see me are going to get worse. So their stream is going to get slower. They're going to have more dribbling. They're going to have more trouble initiating. And the ultimate result is they suddenly stop passing their water. I saw a man today, he was on his way back from Holland, and he stopped passing his water. There were 4 doctors on the plane, if you can believe it, and KLM, we should all fly KLM, they have catheters on board, and they were able to catheterize him and relieve him of his obstruction. So that is the ultimate end result of having trouble peeing, is you suddenly stop passing your water. And that's most unpleasant. It's one of the reasons I went into urology, because if you relieve that kind of obstruction, people think you're Tiger Woods, like awesome. Some people won't get worse, they'll actually get better, and that's just that there's a natural history in the body of things get better, some things get worse, and then some people will stay the same. You'll just be exactly as you are. So basically 50-50. You may stay the same or get better, and 50% you may get worse. And it's the getting worse stuff that we don't like. Why would you possibly treat prostate enlargement? Okay. keeping in mind that we haven't necessarily ruled out prostate cancer. And remember, you can have both together. And I know it's a familiar story where you saw your doctor and you said, "Doc, I'm having trouble peeing." He says, "Try these pills, let's check a PSA." The PSA is up, biopsy, prostate cancer, and down the road there. So you've moved away from the fact that you had prostate enlargement. So it is possible to have both. And there may be men in this room that were diagnosed with prostate cancer, but it was a very early pickup and they're being watched. It's what we call watchful waiting or surveillance. So that whole time you're on surveillance, you may say, "Wow, my stream is slow, I'm getting up at night, and it's bothersome. I'm really worried it's the cancer." You got to remember, it may not be the cancer. It may just be prostate enlargement. And as a urologist, we may be able to treat those symptoms, and it may or may not affect the cancer. So it's possible to have both together. Our main reason to treat this is not cancer. It's just to make your quality of life better. You came to see me because you're having trouble peeing. I want to see if I can make you pee better. I want to prevent that sudden stoppage of urine. That is a most unpleasant experience, and if any of you guys have gone through it where you suddenly stop passing your water, literally I could probably ask for money with a catheter like this in my hand, and you probably would pay me any amount until I pass this in, because it's such excruciating unpleasantness to not be able to pass your water. And then ultimately, why would we treat it? Because we're trying to prevent the rotor-rooter, or the green light laser that we're going to get to. And these are the things that I'm worried about with prostate enlargement. Bleeding of the prostate is possible, infection in the prostate or bladder, sudden retention, that's where you can't pee, intolerable symptoms, that's where you live in the washroom. You sleep on the toilet, you don't leave your house because you need the toilet and you need it right now. And then bladder stones. So anytime the bladder doesn't drain, it is possible for the urine to settle, precipitate out, and start to form some stones in the bladder. And all of those are potentials, and those are all the things that I list in my mind as to indications for treating prostate enlargement. So what are the options for fixing it? Well, as physicians, we always start with what we call lifestyle. Now, those are easy to say, but often quite difficult to do. Eliminating caffeine is difficult. It'd be tough for me. Look, I got coffee here right now. It is decaf, but I love my coffee. So cutting back on coffee is always a great place to start when you're having trouble passing the waterworks, because it's an irritant. It's a volume of fluid, as well as it can cause the twitchy, jumpy bladder that I've spoken about before in my other talks here. Fluid reduction, a lot of people feel, "Oh my goodness, I really need to get my 8 glasses of water in per day." It's actually a health myth. There is no proven benefit to drinking copious quantities of water. It came from a obituary of a nutritionist in the 1970s, and they said his good health was credited to 6 glasses of water, and it became a dogma that we must drink water. So many of you are forcing water down. You hate water. You're drinking it day and night, and you're passing water all the time, and your life becomes basically dictated by the toilet. A reasonable place to start, and you heard it from me first, is cut back on the water. Now, if you make kidney stones, I didn't tell you to stop the water, because those people need to drink water. But if you don't make kidney stones and you're flooding yourself with 8, 10, 12 glasses of water per day, living in the toilet, ease it back, and it's a good place to start. And I'll take any abuse you want to tell me about drinking water, because it's definitely something that I spend a lot of time undoing for people, because they feel almost guilty that they don't drink this water. Medications, many of you may have been on a Flomax or an alpha blocker in the past. Natural products, many of you leading up to your diagnosis of prostate cancer may have been on saw palmetto. Vitamin E and selenium were prostate supplements that have recently appeared to not be dangerous, but the potential benefit of vitamin E and selenium seemed to have been undone in a large study. But saw palmetto, pumpkin seed, African pygeum, these are natural products that you can often buy over the shelf. They do work for prostate symptoms, but when you put them into studies, they haven't held water, and so they're not recommended by urologic associations. I'm not going to argue that they work, because people do claim that they work, but there are natural products. And then surgical options. The TURP, that's the Roto-Rooter, the green light laser, and then an old-fashioned operation called the open simple prostatectomy, and we'll touch on that. So again, there were two components that I needed to treat. One was the prostate enlargement, and that was with a 5-alpha reductase inhibitor, or prostate enlargement. The other is the muscle, and that's what we treat with the alpha blocker. So alpha blockers, this is the first thing. If you watch golf, if you watch racing, anything, you'll see Flomax advertised, the BPH boys. And that's because Flomax is a great medication. It works very quickly. Your doctor gives you a 10-pill sample, and within 5 to 7 days, you feel your stream is stronger, things are better. And it works quickly, and it works in over 50% of men. Right away, they'll start to feel better. And even some of you that have had brachytherapy, after your brachytherapy, the cancer doctors at the Tom Baker may have put you on Flomax to try and help you pass your water. And that's because it's trying to relax these muscle fibers. It does not affect your PSA. So starting on Flomax doesn't affect your PSA up or down. It just relaxes the prostate, doesn't shrink it. In this province, Flomax CR would be our first-line therapy. It's 1 pill once per day. And it's in general very well tolerated. There are other agents. Hytrin is a much older medication that some of you may still be on. It's called Terazacin. It's also used in blood pressure. So if you have a high blood pressure and prostate enlargement, about 5 or 10 years ago, your doctor may have put you on just Hytrin. Zatril is not covered by formulary in this province, so it's rarely used. In general, they're well tolerated. 4% of men may get a stuffiness in their nose. Some people feel lazy or tired. And then retrograde ejaculation, that is when you ejaculate, instead of it shooting out, it goes back in the bladder and comes out later with the pee. It's not a huge risk with the medication, but it's definitely something I tell men, because if they wonder, what the heck happened? It's because of the medication relaxed your prostate so much that your ejaculate didn't shoot out, it went backwards. Maybe more of a concern to the younger man, but one thing you learn in my job is people have sex at all ages. Some people stop early. Some people want to go right to the end of time with sex. And so that's why I tell men retrograde or backwards ejaculation. And I bring that up, rare sleep disturbance, because I've had the odd person that came back and said they had nightmares or they didn't sleep as well. And in the fine print on the medication, it is listed. But in general, very safe medication. Even many of you that have had prostate cancer therapy, unless we've removed your prostate, if you're having trouble passing your water, we may put you on this medication, because if you didn't have your prostate removed, you still have a prostate, and so it's worthwhile us trying this medication to relax your prostate, even if it's been radiated or had seeds implanted or frozen. 5-alpha reductase inhibitors, that's Proscar and Avodart, and those are pills that relax and shrink the prostate. So they work to actually reduce the size of the prostate, therefore opening the water channel. Here's one of our fancy medical diagrams. The reason I bring this up is to show that these drugs work by stopping the conversion of testosterone to DHT, and it's the DHT that's actually required for the prostate to grow. And so they work in that division there. So you don't go on the pill and all of a sudden feel like you want to go shopping and all these things that can happen when your testosterone goes low, where you may feel menopause, basically. These drugs don't cause menopause. And I should bring up again, some of you in this audience will be on hormone therapy, and you're on the Eligard injection. They may have put you on the flutamide or nalutamide. In this province, we mostly use flutamide or bicalutamide. And then they may have said, I want to add a third-line therapy, and that may be a Proscar or an Avodart. And so some patients on hormone therapy actually are on 3 different therapies, and that's because we're trying to block any testosterone from seeing the prostate. And so these drugs, you might say, why am I on this? I don't have an enlarged prostate. It's being radiated, and that's because we will take advantage of this conversion in our practice. Now, these don't work right away. I will tell you, I need you to take these medications, and you may not notice anything for 1 month, 3 months, 6 months. And that's because it takes quite a while to shrink the prostate. What you will notice is your PSA drops in half. Now that's important because you came in with a PSA, say, of 5, and now it's 2.5. You're feeling really good. You're telling all your buddies your PSA has come down, but it's actually artificial. It's dropped because the medication has reduced the DHT, which is important for PSA production. PSA being a normal enzyme produced by the prostate. Now, I'm happy to know it went lower, but I also need to keep an eye on it because if it rises, there's concern of prostate cancer. Recently, there was a huge study, I'm going to come to it, about this medication called the REDUCE trial. That was released in April, and basically it is being shown now with Proscar and Avodart that these medications may reduce your risk of developing prostate cancer by 25%. 25% is huge when we've got a cancer that is in 1 in 4, 1 in 9 men. Again, in this room, if you've been diagnosed with prostate cancer, I don't believe it's necessarily a treatment for prostate cancer, but if you have sons and they don't like seeing what dad went through, this is huge. A reduction of a cancer by 25% from a medication that you can take every day that doesn't have huge side effects may turn out to be one of the biggest things that we've been involved in. And that it is not on formulary, so it's not written on the box, that fancy sheet that you open up from a pack of pills. It has not been adopted yet by Health Canada or the FDA. But if you have sons or nephews, and they're asking, is there anything we can do to prevent prostate cancer? Because I don't like seeing what you went through, uncle or dad. These medications may turn out to be huge, and we've now proved it with both drugs, Avodart and Proscar, and Avodart is the most recent. But more importantly, if you just have an enlarged prostate, these drugs drop your risk of suddenly stopping peeing by 50%. They needing surgery by 50%. I mean, that's huge for a medication. Finasteride or Proscar, you'll also remember maybe hearing that this grows hair. Like I tell patients, if it grew that much hair, don't you think I'd take it? Because I got a cupboard load of it. It's not a miracle. It's not going to cover me back up. But people that are on it, they may say, I'm starting to get a little bit of peach fuzz and it seems to be growing in. They may notice that the amount that they ejaculate goes down. They may notice that their mojo can fall a bit and that their erections aren't as strong. But again, those are very low numbers. And the medications are very safe, and the prostate cancer reduction may be very important. Avodart is the other one, and both are covered for over 65 men in this province. Good pills. So if you've got Flomax or the alpha blockers and you've got the 5-ARIs, which shrink the prostate, what about together? Absolutely. Often if you come see me for prostate enlargement, I'll start with the Flomax because I know you're going to get the benefit sooner. But if I really believe you've got an enlarged prostate over, say, 40 grams, that's kind of our cut point, then we may do a combination. 2 is better than 1. And that's because we're relaxing and shrinking. And so a lot of people will leave seeing me with not 1 pill, but 2. And with time, we may be able to reduce 1. What we're trying to do is stop you from suddenly stopping peeing, which is miserable, or maybe needing to go on to a Roto-Rooter. The medications, though, why don't people stay on medications forever? Well, they don't work for everybody. They always have side effects. Some people would love to get away from medications. And there is a cost. If you're under 65 and you don't have a drug plan, these medications carry a significant cost for you. And so you may say, is there something else I could do? And just a word on natural products. The Canadian Urology Association and the American Urology Association haven't been able to recommend a certain herb or phytotherapy. And that's just because at this point, we don't have one proven in a randomized study to say that works. The most common one by far is saw palmetto. And a lot of people will even be on that right now. So indications for surgery. As a surgeon, the things I'm trying to think about are your medications fail and you say, "Doc, what else can you do?" You stopped peeing suddenly, that's miserable. And if your urine is backing up in your bladder and it's affecting your kidneys, if you're getting bladder infections, stones in the bladder, or you're having episodes that are bringing you back to emergency with passing blood in your urine, those are all reasons that I may say, you know what, the pills just aren't working here, let's move on. There's 3 main types of surgery. So there's the standard TURP or Roto-Rooter. And again, some of you in this room may have actually had your cancer diagnosed on a Roto-Rooter or transurethral resection. And that's what got the ball rolling, because the surgeon said to you, "I did your Roto-Rooter and we found a bit of cancer in there." And that may have led you down to needing treatment for your prostate cancer, even though you went in because you're having trouble peeing. The green light laser we're going to come to in the open simple. The open simple is an operation we rarely do anymore, and that's because we've got other ways to deal with it. It was really designed for large glands, more than 150, 200 grams, and as a surgeon, it was a fabulous surgery to do. It's a lot of fun. Now you always want your surgeon to be having fun, because then you know they're in it, they want to be there. So you made a small incision, much like your radical prostatectomy incision. You actually opened the bladder or the capsule of the prostate, and literally you did exactly what you would imagine if you wanted to get the fruit out from inside of a grapefruit and not disturb the outer side of it. And that is how you took the meat of the prostate. It's not a prostate cancer surgery, because you're not removing the entire prostate. You're just removing the adenoma or the enlargement. We would do it when you had bladder stones and a huge prostate. In 5 years, I've done it twice. It's just so rare these days, because we're usually able to deal with it down the penis in a less invasive way. The Roto-Rooter, that is the gold standard. That is what we measure everything against. And that's for surgical treatment of enlarged prostate. People do great with it. They pass water, they can pee over the fence, they've got great flow, and it's what I call the Roto-Rooter job. In that surgery, we go down the penis with a telescope, and then we take an electric loop, and we basically just start to take chunks away of the prostate and create a nice opening. And if you can believe it, I showed my wife this at dinner last night. I'd finished eating and I was working on the talk, and I said, "Hey, look what I found." So those are prostate chips. Those are the things that we are scraping out of the prostate. She wasn't too impressed. My son, he's 6, he thought it was neat. And this here, now it's a smaller picture, but that's a standard Roto-Rooter, and you'll see the blood vessels there. So basically we're up inside the prostate, and we're taking an electric loop, and you're creating those chips. Those chips are actually floating back into the bladder, and you're going to go after them. And it's a combination of electricity, what we call coagulation, and cutting. The cutting is how you get the chips, and then the coagulation is how you stop the bleeding. And it is pretty much a Roto-Rooter. It's sort of disgusting looking at it this way, but again, as a surgeon, it's a great procedure. It's something that we really like doing. It's one of the most common things that we do, and it's the gold standard that the green light laser had to be compared to. Now, we'll go back to this. So, what are the risks of the Roto-Rooter? If I was doing this procedure, I would say there's a risk of infection and bleeding. After the procedure, you usually stay at least 1 night in hospital, sometimes more. We usually have to have what's called a 3-way irrigating catheter inside your bladder. And don't tell the minister that I did this. This is a 3-way catheter. You be at the back there, you're like, wow, that's huge. Yeah, it's absolutely huge. This is a large catheter. We pass up the penis, and there's 3 ports. One is irrigating or washing out the clot, one is draining, and one is for the balloon. Many of you have had a catheter at some point in your life, but you may have had the smaller one, and this garden hose is because that prostate, after the surgery, you'll pass blood, and so we need to wash out the bladder overnight and prevent you from developing clots. And it is, again, the gold standard. It's a great surgery, but it has risks of bleeding. It has risks of incontinence. Those are mild risks. There's a chance that it'll grow back. And there was something called the TUR syndrome. And that's because the whole time you're doing that surgery I showed you, you've got to be running fluid. And that fluid can actually be absorbed into the blood system and can basically dilute out your salt and make you feel really gross. It's a rare complication. It's one that we're always mindful of. But it's the reason why some people said lasers must be able to be used. And people love the word lasers. It sounds really neat. And it is neat. And that's really why the green light laser came about. It came about because the standard surgery can be invasive, hospital stay. You require a general anesthetic or spinal. There can be side effects, and you may be restricted after your surgery. I usually tell people 3 to 4 weeks avoiding heavy lifting. And that's because that great big thing that I scraped out there, that needs to scab over and heal. It's much like a road rash. If you laid down your motorbike and you created a big scab, that thing has to reline itself. And even though you can't see what I've done a big surgery inside to open up the prostate, and that whole area has to reline itself. So you're feeling so good, you think, I'm awesome, you're passing your water better than you have, and so you decide to build a deck with your son at week 2. You lift the lumber off the truck and you go to the bathroom and whoo, out comes blood. And if it's bad enough, you'll stop peeing and we're back to the garden hose. And so that's why for 3 weeks after, I get you to avoid heavy lifting and straining. And it's a reason why a less invasive therapy might be good. Now, that is it. That is the machine. That is the one that was the controversy. It's basically an entirely compact device. And I'm show you here. There's a laser fiber that you hook up to the device, and then you pass that laser fiber, which you'll see the end here. It's a very nicely designed fiber, out the end of the scope, and then that is what you will do the procedure, and I'm going to show you in a second. Why is it even an option? The reason being is that it works, and it works by vaporizing. So those chips that I, for some reason, felt I needed to show my wife and son during dinner, those chips don't exist. There is nothing, your prostate becomes gas bubbles that pass out in the water. So if you said, well, doc, was there any cancer in my specimen? We don't know because we didn't look. Now you'll say, well, that's no good because I want to know. But in actual fact, something I haven't shared with you is the prostate, although it is shaped like a walnut, the inside, the transition or the central part tends to be where the prostate enlargement is, and the outside part is where the cancer is, peripheral and transition. So when we're doing Roto-Rooter, by and large, we're treating the middle part, and so it's not really a cancer diagnosis. And so vaporizing it is not a big detriment to the man that you didn't get tissue. But the reason the green light laser is it's virtually bloodless. And we're ready now to show you. This one's not nearly as gross as showing that other one. And so here is the green light laser. I won't show you 15 minutes. But I will show you a video if it. Are you guys seeing anything? That's funny, I don't see anything. So on my screen, basically that's a ureteric orifice. This is just inside the bladder. The man's just, the doctor doing it is just being careful. There's the fiber up the center of the scope, and you're pressing on the foot pedal, and you're basically creating room right now because everything's a bit tight right now, and so they're going to stagger it. But they're basically with this, instead of taking those chips, you're flowing the irrigation. There's water flowing the whole time. Those bubbles show you that it's working, and the device is basically just vaporizing the prostate, and it's creating an opening. The guy here, the surgeon, is just getting going, and so he's just creating basically a working space. And that's what it looks like. Now, the difference is really that it is bloodless. You can actually be on your Plavix, you can be on your Coumadin or your warfarin, you can be on your aspirin and have this done. and you can potentially go home the same day with or without a catheter. So from a government point of view, not having a hospital stay and a much shorter hospital stay is very appealing. What's the catch? Well, the fibers are one-time use and they're $800. You might say, $800? Holy crap. But in medical dollars, that's like, show me a big deal. It's really a small amount, especially when a hospital stay is $2,000 per night and a fiber is $800, and you may save 1 or 2 hospital stays with the green light laser. So on this, he just keeps basically looking around, but you will not see a bleeder. You just don't see anything there that is bleeding, and he's going to make a decision here at a certain point that he's getting finished. There's a bleeder right there to coagulate. That's all, and he's going to press on the pedal, and he's going to go zap, zap. It's really cool, eh? It's a lot. It's, you know, it's fun. It takes 14 years to become a urologist like me, but you get to do some really neat stuff. And so he's just making sure that things are not bleeding. Now you might say, wow, look at that, he's bleeding. But in actual fact, everything is magnified on what we're doing on the screen there. And so with a standard TURP, what he's spending time going after, you would barely even spend any time on that. And here, because the surgery is virtually bloodless, you spend time on the single red dot there. And we'll go back to the procedure here. So it can be done in an outpatient setting, meaning you can go home the same day, and there's potentially some benefits to the cost and side effects. What is green light? It really is the wavelength of green light. So Roy G. Biv, the G part, is the 532 nanograms. And why green light? Why does the laser select that out? And that's because the target molecule, the thing that absorbs it and blows up, is actually hemoglobin, oxygenated hemoglobin. What a perfect target. Blood cells that are oxygenated going through the prostate absorb the wavelength and go like that. And that's why it's virtually bloodless. You have to be very close to the tissue. And the other thing about it is it's not like a laser like on TV where it goes right through your body. Even if you put it on your skin, it only burns 1 or 2 millimeters. It doesn't go in one side and come out the other. So that's the beauty of it. It penetrates, it hits oxygenated hemoglobin, and then it vaporizes it. But you would literally have to keep your foot on the pedal and keep your laser fiber on the prostate until you finally dug a hole. And, you know, that makes for a bad day for a surgeon if they do bad things. So we tend to not do that type of stuff. We want to try and do a good job. Again, we have a coagulation and vaporization, basically 2 different pedals, and that's basically we're trying to get the tissue above 100 degrees to vaporize it. When you're in there, you're wearing glasses, I'm wearing glasses, the nurses and the anesthetists are wearing glasses, and that's because if the laser fiber did break and it headed out, obviously if it hits your eyes, so there's special glasses that block that wavelength of light. If it hits your skin, it would hurt and burn, but it doesn't go right through you. Fire and electrical shock are just because it's a laser, and we have procedures in place. Immediately, you should notice that you pass your water better. You may go home that same day. You may notice that your ejaculation is gone or goes backwards. And it's not the feeling of climax. The feeling of climax will be there, but the fluid that you secrete should go away. A lot of men with this procedure, compared to the standard Roto-Rooter, may have some more burning in the early period. That was definitely a complaint that we had in our initial patients, and we've been doing this for nearly 3 years. And it seems to be a burning that goes away. You still have to watch your activities. Again, I wouldn't send you out to carry your clubs for 18 holes because you may start to get some blood in the urine. You still have a raw surface that needs to heal. Post-operatively, you may or may not get an antibiotic. You may or may not need something like Advil or Tylenol. We get you to avoid strenuous activities for a few weeks after. We get you to avoid being constipated because straining can increase some bleeding. And you can drive after a day or 2, really. Long term, it looks as good as TURP or Roto-Rooter out to 5 years. Now, Why doesn't everybody get a green light? It sounds so good. Okay, as a surgeon, it's slower than the standard Roto-Rooter. Taking those chips out is pretty fast. Burning into bubbles is a lot slower. So it takes longer. So that means if I could do 5 TURPs in a day, I could probably do 3 lasers. You might say, big deal, doctor. But again, it's okay if you're in the room that day, but if I am making you wait for your surgery because I can do less surgeries, you'd rather say, well, the TURP sounds pretty good too. So there's a benefit and risks. It is definitely a great treatment for people that are on blood thinners and can't stop them. So if you have a heart valve and you have to be on Coumadin, if you've had a heart stent and you have to be on Plavix, we can do the procedure with you on it. We can't do the Roto-Rooter with you on those medications. That's just a disaster. We may be able to get you out of hospital the same day. You might say, well, it's pretty nice there, actually, the Rocky View. I've been there, it's really nice. But imagine if you're coming to hospital and you have a prolonged stay. For many people that health is a bit marginal, coming to hospital is a turning point in their life, meaning they then go from being in their home, a couple of days in hospital, pneumonias, immobility, things take over. So there are definitely times where we went to get a patient treated and out of the hospital, passing their water faster. Having a catheter in is less with the green light, and length of stay on average in studies was quite reduced. I wouldn't say our average stay with a Roto-Rooter, a healthy man, is 3.4 days, but if you take all comers, patients that are hospitalized in other parts of the city and come to us, absolutely, we keep people quite a while. So getting people out of the hospital is a big savings. It's also nice to be out of the hospital. And this is just showing that on average people do well. They pass their water well, they report being better, and they would say they'd have it done again. When you compared it, there were fewer complications, and most of those come down to the fact that it's less bleeding. And less bleeding often means less visits back to the emergency, less chance that you need that garden hose back in there, which you're thankful for. There is a cost savings. This is the stuff that should be attractive to the government, and that's basically because the length of stay is shorter. Even though there's a higher cost to the fiber, there is a shorter cost because of a shorter stay in hospital. Now, tough situations. I know my audience here, brachytherapy, cryotherapy, radiation. If you are sent to me and Dr. Angelfi or Dr. Siraj Hussain says, you're having trouble peeing, you need to see Baverstock, he needs to open up your water channel. If I'm going to talk about a Roto-Rooter or a green light and you've had brachy, cryo, or radiation, I'm nervous even before we start the conversation. So just because you've had one of those and you think, I'm having trouble peeing, I'd love to have a Roto-Rooter. If you go see a urologist, you're not like, why does he seem so nervous here? It's because it's always frightening operating on radiated tissue or frozen tissue. And that's because the plane between the prostate and the rectum is unpredictable. And so if you went in having trouble peeing and you left with a hole between your urethra and your rectum, what we call a fistula, you'll wonder why we were nervous to start with. And so that's why we do what's called a gentle resection if you're in that situation. So I'm finishing up. BPH, common condition. Medications are first line, surgery therapies are there, and the green light definitely has a role for some patients. I don't think it replaces the standard TURP yet for every surgeon in every situation, but I sure am glad that we've got it in Calgary and it looks like it's here to stay. Okay.
A few questions.
Is there much advantage to taking Novodart as well as Flomax?
So the Avodart in addition to Flomax. So for a man with a prostate enlargement, and as a urologist, we have certain criteria. If your prostate blood test is over 1.5 and your gland is over 30 grams, we think there's a benefit to being on both medications. And so you'll find that most of the time you'll start with Flomax. If you didn't get the benefit, you'll end up being on both medications. And absolutely, if you've got prostate enlargement, I think there's definitely a benefit to being on both, for sure.
I was just curious, why medication, the recommendation medication should be the first choice over surgery. You know, if you're to the point where you really want medication, and I assume you have to stay on medication a long time, on medication. Surgery, both options seem very reasonably priced, more permanent solution. The drugs always have side effects. Why wouldn't surgery be a higher priority than staying?
Yeah, if any of you guys know Dr. Duffy, Marty Duffy, this guy's a plant, because he he's like, yeah, just terp them. Beaver, just terp them. So absolutely, it definitely would be a first line, but you know, I'm presenting a talk, and most times people will say, oh, try the pill first, especially if it's covered, side effects are minimal, and they get a good benefit. And so it's a reasonable place to start. Plus, you come to see me in the office, I diagnose the problem. Even if we say, let's do a Roto-Rooter, I know I'm going to book you down the road, why wouldn't I start you on a medication? Sometimes we get a home run, but it's different. If you present it to the emergency department, you could not pee, and you say, look, I've had symptoms for a while. Skip the medications, let's go straight to the Roto-Rooter. Because you're right, it is by and large way better than the medications. But for some people, the medications are perfect.
After you've had surgery, the Greenlight surgery, are you required to stay on some kind of medication, or do you recommend medication afterwards, or is it pretty much finished?
Usually, we stop your Flomax and Avodart when you come to hospital. Just stop them and off you go. So usually, it is the turning point. You come off your medications when you have your surgery, and you don't go back on them. Yeah. There's in the orange there.
Taking Flomax, you mentioned that GI problems are one of the side effects. How common are those GI problems?
Oh, it would be unusual, and definitely unusual as a reason to stop the medication. So I'm going to put it at less than 5%. Some people will just feel like you do with a lot of pills. Even Viagra causes GI upset. A kind of unsettled or a heartburn type sensation, but it isn't as common as tiredness, as a nasal stuffiness. But it's pretty much on the package with every pill that we take. But it is possible.
Do you have any comment about possible benefit from soy milk or phyto? I guess it has phyto.
Yeah, I mean, so many of these things. This is what I tell patients. You know, we think we have all the answers with medications, and then a well-designed study, or with natural products, then a well-designed study fails to show it. And I take the SELECT trial, vitamin E and selenium. We thought that was a great treatment for prostate cancer prevention, and it was halted by the FDA because there was slightly increased risk of prostate cancer in the vitamin E arm, and also in increased risk of type 2 diabetes in the selenium arm. So it was halted. And so, hey, we thought vitamin E was the answer. And usually the recommendation I'll give is, you know, the Canadian Food Guide, Canada Food Guide, the pyramid thing, it's not a bad thing to follow. And things that Mother Nature tends to make for us in eggs, fruits, vegetables, nuts, they're pretty good. And so my dad, he's a doctor, he believes you're just making expensive urine by swallowing all this stuff off the thing. Even you take vitamin E, it ends up in the toilet about an hour later. So if you like soy, it's probably good, but I don't know that you're doing much for the prostate yet. Even cooked tomatoes, lycopenes, we think it's good, but it doesn't, we don't know. That's all I say. Yeah.
I waited 3 years for a total knee replacement. In terms of wait times and government dollars, can you give us a rough idea of the wait times?
Oh, much quicker. So let's say you left here tonight and you showed up at Rocky View and you could not pee, and you say, I'm not leaving to have the Roto-Rooter. We will get it done this week. The guy on call will get you done. If you are having trouble passing your water, you see your family doctor. Most of us will see that man within 3 months. We'll initiate a therapy, and then, but if you say, I want surgery, most people will get you done within a couple of months. So I think inside of 6 months, you can be Roto-Rooting. And it's pretty quick. And if you present with can't pee or clots in your bladder, we can get you done pretty quickly, and we have a really good system in place to get people done fast.
Or the age limit after which you will not recommend to do the green light laser treatment?
Well, in actual fact, the older, the more attractive the green light laser becomes. And why is that? It's because if you're 97, and 97-year-old people stop peeing, when you're 97, you're fragile. Even if you're off, everybody says, he's a fabulous 97. But I don't want you coming into my ward, this is being totally honest, because I'm not sure you'll ever leave, right? And so if I can do a treatment that you get home that same day, or I can even send you back to your lodge the same day, what a great thing. Whereas if I need to put this in, maybe give you blood, lots of bleeding, I may never get you back. So no, I won't use an age criteria. But let's be honest, the only part I didn't talk about is, let's say you stop peeing, but you're just too medically fragile. An indwelling catheter that goes to a bag and you live at your nursing home is still a reasonable option. It's one of the options that definitely should be considered. So if you're old and fragile, you don't know where you are, an indwelling catheter might be a reasonable option to start with.
Okay, one more question?
Can you be confident when a GP just is watching your prostate because it's enlarged? Or should you be seeing a specialist?
Yeah, so the question was, can you be confident if your GP is just watching an enlarged prostate? So watching prostate enlargement, I think is totally fine, because again, it's mostly quality of life threatening. As a man, things you'll want to know is, well, did you feel any lumps on my prostate, so hard nodules? And is my PSA acting appropriately? Is it within the normal values? Is it not doubling? Is it not racing up? Is there not a concern of prostate cancer? Because those are red flags, and we want to see it right away. But if you say, you know what, doc, I get up once or twice per night, but I get back to sleep, or my wife and I sleep in separate bedrooms anyway nowadays, right? So it doesn't bother her. And I'm not overly tired, and I'm around house all the time, then I don't have any problems with somebody keeping an eye on it. But obviously, especially for this organization, ruling out prostate cancer is a factor, and that may require me to see you. And then if you're not overly bothered and you don't want to take any pills, absolutely watching it is fine.
Richard, thank you again so much.
Well, you're welcome.
And we appreciate your time and your effort. And we just have a very small little remembrance for you to take home and remembrance of your visit.
Thank you very much.
Thank you very much.